Okay, so we will start it with the blank. So what is CTV? So CTV is the Congenital Talipes Equinovarus. So in the short form we call it CTEV, and in general term it is also known as Clubfoot. So what actually happens? You can see in this picture I have shown two pictures. One side on my left you can see the normal foot, and on the right side you can see the congenital club foot or CTV foot. Can you see the difference? Okay, so this is the one more clinical picture. Here you can see the foot from the front side, and this is from the back side. So the sole is not facing downward but the back side. Can you make it out? Okay. So for introduction, what is clubfoot? Clubfoot and CTV. This is a condition which is congenital. Congenital means it is present since birth. So, and talipes is a Latin word which means ankle and foot. Equinus is a term which presents that the heel is in this elevated, and whereas the foot is turned inward. So as we know, if we take the central line of the body, if something goes towards the center, it is varus, and if it goes away from the center, then the condition is known as the valgus. So incidence, it is about 1 in 1000 live birth. Every 1000 live birth, there is one CTV child. It is a development deformation. Normally, a developing foot turns into a clubfoot during second trimester of pregnancy. Rarely detected USG before 16 weeks, but it is detected in the prenatal period in USG. The patient will come to you, or the parents will come to you after the delivery of the patient, or many times the parents will consult you before delivery that USG report has shown this thing, so what should we do? Should we go with the pregnancy or not, or should we consider for any termination of pregnancy or something like that? So this is a totally curable condition, and the child will become normal. You have to assure the parents. So then etiology, mostly it is idiopathic. There is no such reason. It is more common in the first born child, and especially in the females or males. And then there are the other causes, likely your neurogenic, that is cerebral palsy, spina bifida. Then osteogenic causes are also there, that is tibia hemimelia. Tibia hemimelia means when there is a absence of the tibia, or then there is osteogenic causes, syndromic causes like arthrogryposis, congenita, amniotic band syndrome. Okay. Then there is a pathological anatomy. So what is really happens in a case of a CTV or with the child with a CTV? So in this, the heel is in varus. Oh, sorry, the heel is in equinus. The hind foot is in varus. The midfoot, there is an increase in the cavus, and in the forefoot there is an adduction. So this is a basic deformity that is found in the CTV case, and in examination the examiner will ask you about this. If you talk about the practical case, he will just ask you, just show me what are the deformities. You have to show these deformities. Yes sir, the heel is in equinus, the hind foot is in varus, there is increase in the midfoot cavus, and forefoot is in adduction. Along with, there is also one deformity present, two deformities present. First, there is a fall of the first metatarsal head, and second, there is the internal torsion of the tibia. So evaluation. So to evaluate it, we should have something कि है जिससे हम बता सकें कि हाँ भी इसमें क्या है या क्या करना है, कितनी सिचुएशन सीवियर है या नहीं है. To define that, there is a scoring that is known as the Pirani Score. तो इसमें midfoot and hind foot, दो only two things are considered, that is the midfoot and the hind foot, and the maximum score is your 3, and it depends, as I have you can take a picture of this, the Pirani score. You can see that this midfoot and hind foot, only two are it is based on only these two components. So in the midfoot, there is the midfoot, what we consider is the lateral border, and in which if it is curved, then if it is straight, then it is 0. If it is slightly curved, that is 0.5. If it is severely curved, then it is 1. and the middle foot creases. If more than one, if no crease is present, then 0. If one crease is present, then 0.5. If more than 2-3 creases are present, then score goes 1. Then there is a talar head coverage. If the talar head is totally under your tibia, then it is score is 0. In moderate condition, if half of the head is getting covered by the tibia, then it is 0.5. And if fully covered, if it's not covered at all, then the score is 1. Then comes the hindfoot score. In hindfoot, that what we see, posterior creases. If no crease is present, then it's 0. If one crease is present, then 0.5. And if multiple creases is present, then 1. Then rigid equinus. If it is not coming at all, then 0. If it is coming into dorsiflexion, then 0. If coming slightly up to the neutral, then it's 0.5. And if it is not coming at all, then the score is 1. And then the empty heel sign. When we compress the heel, if we can feel the calcaneum there, then it depends on that. If we can feel the calcaneum, then the score is 0. If slight feel is there like your nose, then it is 0.5. Like lip feeling, then is 1, means severe. So the score is, maximum score is 3, like this. So maximum score will go 6 and 3 and 3. Okay. So 6, as the score goes higher, the condition is more severe, and the it will require more effort to make the foot straight. This is the pictorial description. You can see here the midfoot is straight, here slight curve is there. You can see here the amount of curve. So this is 1, 0.5 and 0. Then this is lateral curve border. You can see. So what are the treatment options? There are the two options. One is the non-operative option, and the second one is the operative option. So in the non-operative option, the options are the daily manipulation by the mother, along with we can do some strapping or something like that. Then comes the kites technique, which was earlier used, but the fulcrum at the time was the calcaneocuboid joint, which was at fault, and it causes the rocker bottom foot deformity. That's why it is absolute now. The third and the most common is the Ponseti method, which is widely used and widely accepted. So what happens in the Ponseti method? So this is Ponseti method. It is actually a procedure in which there is the serial casting followed by bracing. So you can see the foot here at the initial time. You can see the deformity of the foot. So in the first cast, what we do, we correct the cavus and the fall of the first metatarsal head. We correct that thing, and after first cast, the cast looks like this. Then after correcting the cavus and the drop of the first metatarsal heads with the serial casting, we correct the this adduction and the adduction part of the foot. So you can see this is the second cast, this is the third cast, this is fourth, and this is in the fifth cast. So after fifth cast, the foot goes like this in the abduction. After achieving around 30 degree of abduction, we go for the percutaneous tenotomy. After tenotomy, what we do, we apply a cast, that is a below knee cast or a Ponseti cast, that is kept for 3 weeks. After 3 weeks, the cast is removed. Then the child is given the brace like this. You can see. So what is the purpose of this brace? So even after, if you correct the deformity, the foot has the tendency to come back into the deformed position again, and to prevent that deformity to relapse and to reoccur, we need this brace. Okay. So what are the can anyone tell the name of this brace? The most commonly brace used is the DB brace, that is the Dennis Brown brace, but nowadays it is quite costly. So in Indian scenario, we use Steenbeek brace. What is the difference between a Steenbeek brace and in the DB brace? In the DB brace, you can adjust the angle of the foot and angle of this, the amount of abduction you want to achieve. Okay. But in the Steenbeek, this is fixed. So you cannot change that further. So in case, if it is a case of a bilateral CTEV, then Steinbeck is good. Steinbeck brace is good because both the foot are in the 75 degree of abduction. But in case of a unilateral case, if you are applying a Steinbeck brace, then it's not good for the patient because in the recommendation for the unilateral CTV is that on the effective side there should be abduction of around 75 degree, and on the normal side the abduction is around 45 degree. But in Steinbeck brace, both the foot abduction is both the foot are in 75 degree of abduction. So it is better to use a DB brace if patient can afford. Obviously it is more costlier than that. What are the operative techniques? So as first operative technique, I have told you the tenotomy part. So usually previously there was some recommendation that only casting is required, but now at this present time there is the recommendation is that tenotomy is must for each and every case of CTV. Otherwise it will cause relapse of the foot and the equinus deformity will not correct fully. Secondly, the deformity will, the thing is that if you forcefully push the foot correct the equinus, it will cause the flattening of the talus head. So tenotomy should be done. It is mandatory step. Then comes the PMSTR. PMSTR, the full form is the posterior medial soft tissue release. So this is operative technique. It was previously PMSTR was the only the treatment which was done. But nowadays only really PMSTR is done. Only few selected cases, especially like your arthrogryposis or some rigid cases, or some in case of the spina bifida where the foot is not coming even after casting, then we can go for the PMSTR. Okay. Then come the mid JES part. So in the case JES is the Joshi External Stabilisation System. So when JES is used in cases where there is a late presentation of the CTV, means CTV is present since birth, but the patient or the child is coming to you in the late period, like at the age of 4 years, 5 years, 6 years. At that time you cannot apply cast weekly because the child will not cooperate. So you have to do some surgical part, and then there comes this JES part. JES is Joshi External Stabilization System. So we apply JES system, and then correction is made gradual. With the gradual correction is made. Then comes this mid-tarsal osteotomy. So mid-tarsal osteotomy, it is also done in the case of the neglected case of the late presentation of the CTB, especially in the age group if we talk about more than 5 to 6 years and in between 12 to 13 years. We can do the mid-tarsal osteotomy. It gives a very good result. Along with that, this your TA tenotomy, TA lengthening is also done. Then come the last part that operates, that is triple orthodosis. This is done in case of the very late presentation of the case after 13 years of age. If some patient comes to you after 13 of age, then the triple orthodosis is only treatment that is left. In the triple orthodosis, what we do the orthodosis of 3 joints. Which joint? First, there is the talocalcaneum joint, then calcaneocuboid joint, then your this cuneiform joint. So these 3 are the joints which are orthodox in the triple orthodosis. Okay, thank you. So this was your lecture on CTV. Generally, a short question will come on CTV, and in your practical examination, there will be you can find a child with the CTV deformity, and question will be asked on that.